This Week in Virology, the podcast about viruses, the kind that make you sick.
From Microbe TV, this is TWiV, This Week in Virology, a special episode recorded on May 25th, 2022. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
Daniel, I thought it would be a good time to do a special episode on monkeypox, and this time you don't have to go to your car in the parking lot.
Yes, this is true. This is true. And I think it's timely because, boy, I am getting a lot of questions. And it's probably also, it's a good sort of public service for us to at least get a little bit of information, hopefully out there to clinicians, to just people who are not clinicians, just what's going on. Should they be worried? Is the sky falling? What should they be thinking about?
So I have a series of questions for you, and I thought we could start with those and have a couple of references, a nice document from European CDC, the latest ProMed Mail post. So let's just start. What is monkeypox?
All right. So it's really nice in this situation, right, Vincent? Because there's monkeypox, the virus, and monkeypox, the disease. We don't have to remember two different things. So monkeypox, the virus, I'm hoping you, Rich, and the team can jump in on, but it's a double-stranded DNA virus. So perfect example when people start worrying about, how do we check for this? It's got DNA just like us, double-stranded just like us. But it's a member of the family, the Poxviridae. So it's in a family that we're familiar with. And there's really, and I think this is really important, there are two different clades, two different groups, two different variants, if people are familiar with that idea, of virus that you can get infected with that are going to give you slightly different monkeypox diseases. There's the more virulent, the Congo Basin or Central African form of monkeypox. And then there's the West African form of monkeypox, which we think has a lower mortality. And why do they call it monkeypox?
It's kind of a misnomer because probably it was where it was first isolated from, but monkeys are not actually the reservoir. It's some kind of rodents, really.
Yeah, and that's perfect. I mean, it was first identified as monkeypox, a pox infection of some monkeys in Copenhagen, in Denmark. This was in the late 1950s. So the Danes can, I guess they can build boats and they can pick up new diseases in monkeys. And so that was where it came from. But no, that's exactly the point. This is an infection that you don't get from hanging out with monkeys. That's not part of your history. Have you been hanging out with monkeys? So it was first identified there in Copenhagen in Denmark, but it really was brought in from West Africa, where in 1970 and then going forward, it was identified. Hundreds of cases in humans have been identified over time, but hundreds, which is going to sort of raise us probably to some other questions. So this is a viral illness. It's a pox disease, and we'll go through a little bit more.
What are the symptoms of monkeypox, Daniel?
So that's key, and I think that's what we want to alert people to, is there really are characteristic symptoms that people can think about. So this falls into that group of fever, rash, and then particular characteristic rash. So, and it is sort of a typical progression. And this is what hopefully people will take away. They'll say, oh, okay, now I'm thinking of that. So in general, the individual has an incubation period, right? We're familiar with that. You are exposed. You're not sick yet. That incubation time can be actually pretty long. It might be as short as a week. It might be as long as 3 weeks, as long as 21. And then the first thing that most people usually experience and that we can measure is fever. So you start off with fever. Couple days later, you start to develop a rash. And the initial rash are these small red macules, tiny patches. Couple days later, you start to get vesicles forming on those red macules. Initially, those vesicles are clear, but a couple days later, they start to fill in with pus. They become purulent. And over this period of time, one of the big, I'll say, two big differentials here is that people start to develop swollen lymph nodes. That's actually characteristic here. Is one of the ways you distinguish it from other types of pox rashes. The other is that all of the vesicles are in the same stage of development. So those of our listeners who still remember chicken pox, I often get a call to come to the ER because I'm one of the few folks who still sees chicken pox because I practice overseas. Here you'll see like maybe a vesicle here, but you've already got a scab, you've already got one crusting over. These are all going to be in the same stage of development, and they're also going to have the swollen lymph nodes.
Have you ever seen a case of monkeypox, Daniel?
Well, as you know, thanks to Rich, we're actually helping, very timely right now. We're helping with a case in West Africa, and we're helping with the diagnostics because that's one of the challenges that we'll, I think, get to is that a lot of parts of the world, you may see what you think is monkeypox. You may have a clinical suspicion, but the molecular tools to confirm that it's a case of monkeypox are not widely available, even in West Africa, where this is an endemic disease.
Is this disease ever fatal?
I think this is the important distinction, and it's a little heartbreaking, right? In the DRC, in the Congo Basin area, we see mortality as high as 10%. The West African variant, we think the mortality is in the 1% to 5%. But we've had importations here in the United States. There was a large outbreak about 20 years ago. No one died during that, and so it's a mix of which of these types of monkeypox, but it's also an issue about nutrition, underlying health, access to high quality medical care. So if someone in the United States and Western Europe develops monkeypox, particularly of the West African monkeypox variant, we're not expecting to see a lot of people die.
So what would you say is the overall risk for the general population?
So it really, the sky is not falling. The overall risk is actually quite low for several reasons. One is transmission. This is not a virus with the right stuff to drive a pandemic. It usually requires pretty close contact for most of the transmission. We don't, even in homes, even in close contact, we don't see a high secondary case rate. There is some, just like chickenpox, some situations where this actually can be in the air, right, where you can breathe it in, where you can get exposure that way. I'm certain there is the possibility of, tiny airborne type exposure. But in general, no, this is not very transmissible. So that's number one. Number two is we actually have tools. We have vaccines, so we have the ability to do these ring vaccination programs. We can kind of surround an area with vaccination. We also have some antivirals, which we think would be effective, sort of limited trial data behind that.
So these latest cases, which began to be observed at the beginning of May, are unusual because many of them are outside of Africa, and I'm not sure that so many have been observed at one time. And there seem to be involved with very close sexual contact in many of them, and that seems to be driving a lot of this. What do you think about that?
Yeah, I think, that was a question that I got, about a week ago. So is this a sexually transmitted pathogen? And my comment was, well, if there is a close physical contact during sex, well, there is. I think unless Bill Clinton is defining it in a different way. But
thinking the same thing.
So that's a concern right now, that there may have actually been an introduction. There may have been sort of the right circumstances where there was a lot of close contact, particularly some of the descriptions as far as epidemiology, who was infected, where some of the lesions were seen. It may very well be that there was a particular super spreader event that occurred, but a lot of those features, those circumstances, we don't really anticipate that becoming or continuing to be a problem going forward.
Some in the press have already concluded that this variant has a new way of spreading, but as you know, the vaccinia vaccine could spread from the scarification lesion to another person by close contact. So is it really a new way of spreading for these viruses?
So I'm not sure that there's any evidence so far it's not as good a story, the truth, right? As my grandmother used to, never let the truth stand in the way of a good story. But no, to be honest, I'm not seeing anything so far that's scary, that's suggesting any new route of transmission. And it is interesting you bring up, and I think it's probably something our listeners might be hearing. And, there's this idea, Rich Condon and I were talking about it just yesterday, actually, that this may be a consequence of us wrapping up our smallpox vaccination efforts. Because it does seem like as we've stopped vaccinating people for smallpox, there may be more cases of monkeypox, the few that we're seeing. But then again, I don't think we have the best surveillance systems. And as Rich and I were saying, if you don't test for it, you won't find it. But an interesting thing in the outbreak that we had here in the United States, that was actually an introduction, exotic pet trade introduction. There were people who had gotten smallpox vaccination that still went ahead and actually got monkeypox. And there wasn't necessarily a correlation with, difference in disease severity, whether or not you had that smallpox vaccine. So sort of an interesting issue there.
Do we know the patients who are involved in this outbreak? Are they all not vaccinated with smallpox vaccine? Do we have that information?
So I don't have that information.
It would be interesting to know. Perhaps none of them are vaccinated, because part of this story is that smallpox vaccine does confer some protection against monkeypox, right?
Yeah, the number that's thrown around is about an 84% reduction. So we've actually at the local hospitals is sort of asking which of the physicians, we have sort of an international community, got their smallpox vaccine growing up, because we're going to send them into the fray, should we have to deal with this on the ground here in the United States.
I got a smallpox vaccine, of course, in the 60s, and I think the last ones were given in the late 70s in the U.S. So maybe that protection is beginning to contract, and maybe that could in part explain more extensive infections.
That would make sense, because, when you say like, oh, we had it here in the U.S. and we weren't seeing this, well, if you had your smallpox vaccination 40, 50, however many years distant, it may not confer that protection that is described.
So if you acquire monkeypox, are there antivirals that we can give you?
So there are a few antivirals that we think could work. There's actually a sort of approved, the TWiV I don't know if I'm pronouncing that correctly. How do I pronounce that? Probably TWiV. I think I'm going to go with that. But there's also, and the way this is supposed to work is it's supposed to interfere with the capsid, right? The protein and the actual formation of the exiting virions, sort of interrupting it at that side. We also have cidofovir. We also have an analog of cidofovir, this brinsitofovir. And then, as mentioned, there is the vaccination. There's Gineo. So we actually have a vaccine, which is a modified vaccinia, attenuated, non-replicating orthopox virus vaccine that we can potentially, and immune globulin is another sort of in our list of things that we can do. But as you can imagine, in most cases, right, in West Africa, this is going to be supportive care. Individual's going to come in, you're going to recognize, you're going to try to keep the skin, clean and dry, try to keep from opening up these different vesicles, purulent vesicles that you see. Sometimes if they actually coalesce and you start to get fluid issues, you want to make sure that this individual stays hydrated. So in most parts of the world, these individuals are actually, going forward with just supportive care.
So if you have a rash already, is that not too late to give an antiviral? Because, for SARS-CoV-2, we always talk about not too late treatment, right?
Yeah. No, I mean, it looks like through this whole period of time, you're having viral replication. And actually, the person, in most of the pox viral infections, the person is the most at risk of spreading it to others is when they have these vesicles that might open, that might burst. They're going to become even more infectious if they have a pulmonary aspect of this.
So if we do have a stockpile of smallpox vaccine here in the U.S., as you know, and I suppose if the cases continued to increase, which I don't know is necessarily going to happen, we could always do ring vaccination, the way smallpox was eliminated, right? It's just vaccinate everyone around a specific case.
Yeah, I mean, we can do that, or we could actually go ahead and use the Jynneos. We actually have a specific monkeypox vaccine. And I know David Friedman, who's now the president of ASTM&H, was actually talking, this isn't necessarily something where you're going to be vaccinating, 350, 400 million Americans to try to protect. It may be more of a targeted ring vaccine targeting individuals who might be at higher risk. So I have to say, having seen, and I think I shared some of those photos with you of this baby girl that we're trying to manage and confirm the diagnosis on right now. It's really it's a frightening disease. But I think we have the tools to control this disease. It's just a question of bringing those resources to bear in a proper, intelligent manner.
Let's talk a little bit about the origin. As we've said today, many cases have a rodent origin of some kind. So presumably some of these originated somewhere in a rodent. Nels Elde showed me some of the sequences they have, the genome sequences of isolates from, I think, 50 of the patients. And they're all very similar. And if you do a phylogenetic tree, they're all lining up, suggesting they have a common origin. So what do you think? Do you think there's one that somehow spread in multiply, or are there multiple origins? What's going on there?
At least the story we're hearing so far, the suspicion, right? So, the reservoir is probably rodent. Again, we're not sure. There's only been actually there's only been 2 animals isolated in the wild where they actually could get the virus. So we say rodents, but again, we're that's what we're thinking. But when you look at the phylogenetic tree, as you're describing, when you hear the history of who was affected, when you put together the epidemiological story, I mean, it is sounding like there was some sort of introduction, maybe a single introduction to Europe, and then maybe that created this spread. So I don't think we're suddenly seeing lots of monkeypox spreading to the United States, spreading to Western Europe. I have to say, from a global health, from a tropical medicine specialist, I'm actually glad that people in the West and Europe are suddenly interested, want to learn about this, because, this is one of those diseases that is very much neglected, in Africa. So even in this situation where we're working with a few colleagues of mine in West Africa, it's nice that people are aware, people sort of have read up a little bit on monkeypox, because I think that this is just another example that we need to know about these diseases for many reasons. One is the humanitarian issue, is being able to help and bring our resources to these areas, but also realizing a lot of these infections, they're just a plane flight away. The case that Rich is helping me with right now, it is a direct nonstop flight from New York City away. So.
Yeah, I think we're in a heightened awareness about viruses now, Daniel. And so in a way, any kind of outbreak is going to get a lot of attention, which, as you say, is a good thing, right?
Yeah, I think it's also because people need to, maybe it's a little bit more humility. People need to keep asking, okay, is this something that has pandemic potential? Because just the fact that, we've been for the last 2 years struggling with COVID-19, that doesn't, mean that we're still not vulnerable to another viral pandemic. So
David Heyman, who you may know from WHO, has said, it seems to be that this somehow got into a population by close sexual activity. And as you said earlier, I wouldn't say it's sexually transmitted because that's a specific way, but just close contact, right? Yeah. And now that's being spread among certain populations. Apparently in Belgium, there was a 3 or 4 infections associated with a kind of what did they call it? Some kind of sexual carnival of some sort,
Okay.
So, and this may have happened before, but we just didn't see it. Maybe we have better surveillance now, and I suspect that it's always been able to be transmitted this way.
I mean, that's an interesting issue. Were there cases that people just didn't diagnose. They didn't come to attention.
Yeah.
When you see a fulminant disseminated case, it's really
It's quite clear,
recognizable.
right?
It's really recognizable, like the case that I shared with you, where you really see these pustules all over the place. They've got this umbilicated feature. You know something out of the ordinary is going on there. But actually, in some of the individuals in this current outbreak, there were just a few little pustules. Maybe they were in an area where you wouldn't even necessarily see or notice them unless you dropped your drawers, so to speak, your shorts. Yeah. There could actually, it is, I think that, what was the comment? Biologically plausible that this has been circulating at some low level, and it wasn't just introduced, but that low level of circulation was sort of before this ended up in this carnival where we saw a number of cases, and then you start really looking, doing the molecular testing, confirming what it is.
So the Belgium is called a fetish festival in the city of Antwerp. So you can imagine that people may have traveled there and perhaps they brought virus with them. Yeah. One of the aspects I think is interesting to talk about is, since rodents are possibly a reservoir, a lot of people have rodents as pets, and they have other kinds of pets. Is it a worry if people are infected and they infect their pets, and now you establish another animal reservoir?
I mean, so that was the introduction 20 years ago, right? It's people like exotic pets, and they bring them in, and there's this, extended incubation period. So, are we quarantining animals long enough, which is really tough to quarantine an animal, for this period of time where they're isolated, limited contact. But no, that is always a possibility, that by bringing in exotic pets, by bringing in exotic animals to our zoos and wildlife parks, that we can be introducing these animals. And then, could that then leave that domesticated, that animal, and end up in our wild populations? That's sure. Always a concern.
Yeah, I think there's specific advice if you go to this European CDC document about be careful if you are infected, not to transmit it to your pets, for example.
And I think that's it. We talked quite a bit about the incubation period, this 21 days when you can, potentially be sort of brewing it and then end up having. But the other side is, while you're going through this, these stages, right? So the fever, the vacuoles, the papules, the vesicles, the pustules, finally those crusts fall off. But this whole period of time, which might be 2+ weeks, you're potentially very infectious. Yeah. If you're out there, I don't know about dogs. We'll have to see. But the concern that you could spread it, not just even to other humans, but to other mammals.
And we should emphasize that the papules are full of virus, right?
Yeah, I mean, that's what's forming these. Yeah, and when these open, these are, that's why we can do the diagnostic test. And I should probably mention this case. The ideal diagnostic test is you're actually unroofing one of those vesicles. You're gathering that fluid, maybe using a non-cotton swab. We recommend sending that off to a place that can do the molecular testing to basically detect that appropriate DNA sequence.
So would most labs in the U.S. be able to do those tests?
So no, this would be, in most cases, actually, this is probably helpful. So in most cases, if you as a clinician see this, you're going to be reaching out to your local Department of Health. Here in New York, it would be going to the Wadsworth lab. They might be working with the CDC. Most of your local labs, this won't be something you just click on your electronic medical record. It's going to take some phone calls, some reaching out. And then, as we recently experienced in West Africa, there are not a lot of places. So that specimen right now is being sent to the DRC, to Kinshasa, for molecular verification.
How can people prevent getting monkeypox?
Well, one thing is, I don't think people need to change their behaviors in any significant way, unless they have a lot of, very intimate contact with at-risk individuals. But no, I don't think this is one of those things that suddenly I'm going to tell people that they need to change how they go about life. But normal things, washing your hands, just normal things that you would do. But no, I don't think that this is suddenly we need to start, changing our behavior to stay safe from monkeypox pandemic.
Nels Elde works on vaccinia virus in his lab, and he says he tries to get people vaccinated. Actually can't get smallpox vaccine for them. But because, even if you have gloves and you get a little virus on your glove, some people would inadvertently touch, say, their eye, and that would be an efficient way, not nice, an efficient way of introducing virus into your eye, right?
Yeah, I mean that's one of those things. Like when I was up there in Steve Goff's lab, and I was doing a lot of this viral work, sort of the BSL 2+. You have to sort of comport yourself in a certain way. Like when your hands are in that hood and you're working with these pathogens. You do not take your hand out and scratch your eye. No. You need to actually practice like proper safety and precautions. And that would be the others. If you are in maybe an urgent care, you're in one of these remote places, someone comes in, they've got a fever, they've got a rash, you're not sure exactly what it is. We always err on the side of caution. What we'll often do is a gown, glove, eye protection, have that N95 on, close the door, negative pressure if possible, till we clarify what it is.
So my last question is, should the world worry? Is this going to be a pandemic?
So I don't think so, and I think I can say that without any sort of hubris or anything. This does not look like it has the features that would really give it pandemic potential. It doesn't really seem like a pandemic potential. But do I think we will see monkeypox in the future? Yes, I actually think that now that people are aware of it, hopefully we'll have better diagnostics. But no, this does look currently like there will continue to be a number of cases in West Africa. I don't expect it to suddenly vanish, so West and Central Africa. But no, do I think this is going to become a new concern in many other parts of the world? I think that's a low likelihood to happen.
That's a special monkeypox update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.